Thank you very much for inviting me along. I'm Tom Waterfield and I'm an academic clinical lecturer at Queen's, and I'm going to talk to you about our study, the seroprevalence of SARS-CoV-2 antibodies in children, prospective multi-center cohort study, or as it's more popularly known, the COVID warrior study. So a bit of background. So obviously, unless you've been living under a rock, you'll know about SARS-CoV-2 this year. When we started this study all the way back at the kind of beginning of the pandemic, there was a few questions that we kind of set out to answer, and a few things that were unknown around children. So we knew that children were relatively spared by SARS-CoV-2, but we didn't really know how many children were asymptomatic, and also what the symptomatology was in children. That was still largely unknown. And these were questions that the NIHR had put out as part of their calls for urgent public health research. Also at that time, and still it's still a bit patchy, but UK seroprevalence wasn't well known, certainly in children. And still a large unknown is the duration of the antibody response, if any, is mounted. So they were kind of our aims. The picture there is just one of our first children through one of our first Belfast clinics. So we set out to try and answer some of those questions in a prospective UK-wide study, which we led from Belfast and from Queen's. We were keen to try and do things the right way, so we developed a study protocol which we submitted and has been accepted for publication at BMJ Open. We developed PPI, and we had a COVID warriors group where we used children and young people through socially distanced meetings, through online groups, to provide feedback and help with the design of the study. And there's one of the COVID warriors with a poster they produced for one of the follow-up clinics, talking about their voices and what they thought of the research. We adhered to the Spirit guidance, which is from Equator, for the checklist for developing the protocol. And essentially, we set out to recruit 1,000 children from across the UK, with sites in Manchester, Glasgow, Cardiff, Belfast, London. We measured blood SARS-CoV-2 antibodies using a range of validated assays, including Roche, Abbott, and Diasorin, and we collected symptom data. And we used our endpoint, our measurement, as the presence of antibodies, and then also the presence of antibodies above the manufacturer's cutoff for reactivity. So the study was designed, we had our patient involvement, we published our protocol, and we began with the first of 3 clinics in Belfast. So the idea was that all the children from across the UK would attend the first clinic, which were in April, May time, a follow-up clinic at 2 months, which was June and July, and then a final 6-month clinic, which are running at the moment, kind of October, November time. So from the first round of recruitment, we had 1,042 children that were identified as eligible across the sites. Of those, 35 were excluded screening. So we had some that were outside the age range. So we included children between 2 and 16 years. We had 1 child who was excluded for malignancy. So we decided, because we're looking at antibody responses, we include healthy children, and these children were all identified from healthcare workers. We excluded children who were on immunosuppressant drugs or had chronic health problems such as malignancy. And we had 16 that declined consent, so these were children that were perhaps interested in taking part in the study, but actually on the day decided they didn't want to have the phlebotomy performed. So 1,007 eligible patients, and we had 15 unsuccessful phlebotomy events. So we only used experienced clinicians to take the blood, so we had a very small number where we weren't able to collect a blood sample on the day, and that left us with 992. And of that very first round, so these are the April-May group from across the UK, with 68 positives and 924 negatives. So we wanted to look not only at the seroprevalence, so there was a big variation with seroprevalence. So in Belfast, it was less than 1%. In London, it was around 12%, with Glasgow, Manchester and Cardiff at around 8%. What we also want to look at, rather than just the antibody, the seroprevalence of antibodies, was to look at where the antibodies, whether they were associated with things like age or symptoms. So there had been some early reports that young children in particular were unable to mount the same kind of antibody response as older children. And the 3 scatter diagrams there, the top left is the Abbott assay, the top right, the Roche, and the bottom left is the Diasorin assays. And you'll see there's no clear pattern. And that's just showing, first of all, that irrespective of age, the antibody response was the same in those that are positive. So there wasn't a correlation with older children, for example, having a greater antibody titer than younger children, which is a really important finding. So children of all ages, if exposed, appear to be able to develop an antibody response. The second part then is a different colour. So we looked at symptoms. So if children reported no symptoms compared to those that reported symptoms, did that affect the antibody response? And again, we found overall there was no significant difference between those that were symptomatic and asymptomatic. The only caveat is that one there, that's the 0.04. There's a very small but statistically significant difference in the mean Abbott assays between those that are asymptomatic and symptomatic, but certainly no overwhelmingly strong data that you need significant symptoms to develop an antibody response. These figures are part of a paper that's been accepted to Archives of Disease in Childhood, so please take screen grabs or share these at the moment. They will be published shortly, and it will be available as an open access document. And these also can be found on MediArchive in our preprint, which we produced. So as well as reporting on the seroprevalence and antibody responses in children based on age and symptoms, we wanted to look at predictors. So here we have a table. On the left-hand side, we have predictors such as age, gender, whether the parents worked with patients or not. So we included a range of healthcare professionals and a control group of around 200 who worked in the hospital but didn't have any patient contact, such as admin, managerial, or secretarial staff. We looked at whether there was a confirmed household contact and then symptoms. And you'll see down the left-hand side, we have the numbers with complete data. Then we have those that reported it in those that had antibodies or evidence of prior infection, those without evidence of prior infection, and odds ratio and p-values. So essentially what we did here was performed a univariate analysis to look at predictors of seroconversion. The people providing the information on the symptoms, the participants were blinded at this stage to the antibody results. So they were given the information prior to getting the antibody result to reduce bias. And what we found was certainly if you have a household contact, that increases your risk of SARS-CoV-2 antibodies or likelihood of seroconversion. Same as if you had a fever, GI symptoms, headache, lethargy, fatigue, changes in sense of smell and taste. Interestingly, things like cough, which are very common in many childhood illnesses, whilst commonly found in SARS-CoV-2 infection, it wasn't good at predicting because it's just such a common symptom in children. Likewise, runny nose, which we've reported elsewhere, is not a feature of COVID-19 in children. We then performed a multivariable analysis to look for independent variables, and the ones that came out as consistent were a confirmed household contact, fever, GI symptoms, lethargy and fatigue, and changes in sense of smell as predictors. But again, cough, not useful in predicting COVID-19 in children. And this is now being mirrored from data from the symptom tracking app from King's College London. So it seems to be real. So discussions, so what next? Well, we have actually completed the second round and we're now in Belfast, the final round of recruitment, and that's running at the moment. The picture there, the Halloween, was we had a Halloween party for our last clinic, and you can see some of the children there in their COVID warrior t-shirts from the second round appointment. What we have found, so we're just starting to look through that data of the children that were positive for SARS-CoV-2 antibodies at the initial appointment. All of them that we attended, so 45 we attended, they all still have positive antibodies at 2 months, and the antibody titer appears to have gone up, although we're doing some work on that. So certainly, I know there's been some reports about antibodies dropping off quickly. Certainly in children and healthcare workers, the early data looks as though the antibody response at least persists for 2 months. We've also collected saliva at the second round, and we're working with Bristol at developing a saliva-based antibody test, which will be very useful in the future. And we're collaborating with a large English antibody study called What's the Story to try and look at this question around antibody titers over time. In terms of testing strategies, we have had some media attention, and we've shared our data with Department of Health and the NHR, and there's definitely room to improve the case definition in children and would improve our testing strategies currently. I don't think that's purely a medical question. I think it's a political one that centres around what we want the track and trace to do. Children are relatively well with this infection, and whether we need to detect all transmission in children is something really for the politicians to decide. What I would say is from this is there is some advice for clinicians. So certainly Many children, so half of the children in our study had no symptoms, and many had symptoms that weren't kind of cough, fever, change in sense of smell and taste. So clinicians, and certainly as we're getting more infections, need to be very careful about PPE, even if you're working in a non-COVID area, because actually it's very difficult in children with children to know if they have it or not. So certainly, even if you're working in a non-COVID area, you still need to be wearing a face mask, gloves, aprons, and using good hand washing. Likewise for parents and carers, we can reassure them to a certain extent that symptoms like a runny nose or a cough are less likely to be related to COVID, but they shouldn't be rushing their children back to school with things like GI upset, because they may well have COVID-19, but just not meeting the kind of current case definition. So thank you very much. I'll take questions. I just need to acknowledge our sponsors, which are Queen's, our funding, which was through the Public Health Agency Needs Met Research, my mentor Sharon Christie, and then the groups that all worked at the different sites, and obviously all the parents, children, everyone else that's taken part in the study. Thank you.